okay? Might be scary to you, but I don't have any problem saying it because we didn't design anything for that purpose. We are designing education for education's sake. And again, I think satisfaction is an important variable, and I think most leaders do. So these are just some numbers, some are real, some are made up, just to give you some idea about things where you might say you had 99% that were good or exceeded good. Again, how you present it could be very important depending upon who you're presenting to. But in today's world, they're going to want to know how you did compared to your basic evaluation of satisfaction, right? And they're going to want to know about things like bias. And again, across multiple stakeholders. So the slide talks about attendees. It also talks about activity directors and the planning committee as part of stemming out of that activity director, et cetera. You know, there is a value that you can do out of industry called net present value. Net promoter value. So you can do a calculation on a 5-point or 10-point Likert scale, where you assume that everybody that is basically an 8, 9, and 10, if you do a 10-point scale, and a 1 through 4 are basically either always going to score you bad or always score you good, and it's the percentage that falls sort of in between that are the important people to identify and try to move, and that's a standard issue in business. Or you can ask it simply, would you attend another one of ours? How does ours compare to what we've taken before? Would you send a partner to an activity that we put on? Right? Those are showing that they appreciate the value and they believe they receive value out of your product, out of your educational activity. So, we're not done in trying to determine value. We have a long way to go. You might be involved in grant review. Our office is. We started a research and education symposium. You may have done some similar things. We participate in the innovation committee at the organizational level, on the simulation board, on PI and risk management as well. We did things a couple of years ago, and I'm just going to present to you the same early data that I've shown before, but we began looking at keywords and core competencies. Again, we wanted to be able to show that we have a diverse educational package. I happen to be at a university wearing that hat for this part of this slide. So we want to be able to show that we match what a university does, which is we have a broad spectrum education. And we began collecting core competencies under the prediction that others would go there. Clearly, I think you're aware that MOC is now going to basically end up having physicians have to show that they've done education across the core competencies. So we wanted to be able to do this and understand it. It also allows us to analyze our program for accreditation purposes, right, in a slightly different way. So what is the appropriate number of lectures or percentage of lectures that should deal with professionalism? I don't know that answer, but it raises that question. It gets us thinking about, are we balanced well? What else should we be doing? What are we missing in our educational package? And same thing when you sit down and start to analyze keywords through the system. There could be consults that you do that are associated with others. Again, the performance improvement aspect. In our shop, we do a number of capstone projects with the Business of Medicine program, as well as capstone projects with an informatics group. And again, you may not be at a university, but you may now think about, could we reach out and be a site where somebody doing an educational degree or somebody doing a Business of Medicine degree or an informatics degree could come and be part of the capstone project with us in your organization, whether it be professional society, medical education company, or otherwise, right? And you can see some of the other issues that we impacted, and again, I'll talk about some of those I'll bring up again in a second. See if this is going to get us to where we want to go. So as I told you in other presentations, what we've done is paused and asked people to call out stuff. I'm not going to do that, but in other presentations, people have focused a lot at how their CME office has outreach aspects to it and helps them meet national mandates like creating their stroke center and doing the education around that, both internal and external. The dissemination of clinical practice guidelines and how their CME office either helps drive the guidelines and or drives the dissemination. They talked a lot about improving communication and family satisfaction, as well as the input into other forms of accreditation that may have been needed in particular shops. Mentorship programs were really stressed by a number. I don't know if any of the tables came up with some of these. Engaging strategic partners. So sometimes the partner starts off as an educational partner and becomes a partner in other ways as you go forward. It promotes educators. It might provide funds. Look at that. Somebody actually finally after that whole part of the talk, somebody actually started to bring up direct profit as an issue. So we were already successful. We already got people to move profit from being the first conversation to being a conversation that's important, but it's not the primary issue. The business is education. The business is not profit generation. So there was innovation awareness that came out of one of the groups of the that we met with, using the innovations, clinical services, compliance issues, a very big problem. SOM stood for School of Medicine in the group that brought that forward. You have the obvious connection to patient safety and outcomes. They talked about making education accessible. Again, the sort of image or brand, the national recognition. Big focus on the growth of team-based education and that value that it'll bring to what you do, and the issue of staying connected with alumni. So I'm going to pause there, just very briefly, and say the important thing I hope I've communicated with you so far is a mental shift. Begin looking at what you do as how you bring value to your organization. Okay, I understand somebody, you're not going to exist. I'm not silly, I'm not stupid. I know that, no mission, no margin, no mission. You have to somehow at least break even, if not make money. But a lot of times you might be doing other things that bring value. And you can win this argument, okay? I made this argument over 6 years ago at Hopkins to the dean and the CFO, the vice dean for education, vice dean for clinical affairs, to the hospital side as well. And to this day, 6 years later, that it hasn't degenerated too far yet. Sometimes the CFO is thinking, I need to talk to you about something. I was noticing the other day on the budget, y'all submitted that. And they'll get about 75% down the line of the discussion and they'll go, oh, I forgot. There's all those other values that we don't give you credit for in the system that you bring. Forget it. Literally, that event, stopping in the hallway with almost that identical conversation, has occurred probably 7 or 8 times in the last 5 or 6 years. So they got it. They got it that there were other values and that we really are a value center, that we bring these other things to the table. But part of doing this is not only for you as groups as you go into the workshop to identify it, but is learning a little bit more about how to think about presenting it, painting the story, painting the picture. Now, we learned a long time ago in my hat wearing, doing quality and safety, that if you wanted to move physicians, and I'm going to say the identical thing applies to this room, you have to touch both their heart and their head. Just let that sink in for a second. A lot of CME is about touching their head. Here is the data. Now go out and do something different. Okay? They need both. It turns out adult education has done this always, okay? You have to give people a reason to change. You have to get at their heart, whether it be a story. This is why professional speaking coaches would say that one of the ideal ways to start any talk is to say, I had a patient, or I have a partner who starts one of his talks on quality and safety about his own experience with his kidney condition of showing up in the emergency room and waiting 5.5 hours to get antibiotics that he knew he needed the moment he showed up, told them, had 6 previous admissions, had a track record, but under a paper-based system and an old triage system and etc., sat around waiting until he went into septic shock for what he knew he needed when he got there. Okay? That's an unbelievable, powerful story to start a conversation about safety and quality in healthcare. It really gets people to open up and think, oh my God, if it could happen to him. Or I used to always look at a physician and nursing audience and say, right, you think your system's wonderful and you're very proud and you'll stand up just like I would about my health system and talk about how absolutely top flight it is. And how come when we get health care, we privately arrange all of the exact providers and sequence. We don't accept the care the system provides. We want a particular surgeon or a particular internist with a particular nurse on a particular OR with a particular day with a particular anesthesiologist. I get those calls every day. Can you hook me up with a good anesthesiologist? Right? We don't, even in healthcare, accept what we do. So you have to move people and get them to understand that they're trying their hardest to provide high quality care. The IOM and the other reports didn't say we provide stinky care. It says we're not providing the quality at the level that we could. We might be at 95%, we're not at 99.996, and that difference is still a huge negative impact. You have to move people's minds and their hearts. Think about that. because that's sort of frowned upon in a lot of CME, right? It's make the room dark, black and white slides, stand at the podium, the person with a pointer looking at their slides, pointing, circling words, like, oh, was it Sing Along with Mac? You know, and not really trying to interact and move with the audience and try to get people to understand. If you do things like get rid of the podium, okay? Imagine that. You get rid of that lectern and just have the riser and have a person have a lavalier. You know what happens? They do this when they have a positive comment they said, and the data is irrefutable. And when the data is weak, they go, we're not so sure this works well. They use body language to begin communicating additional pieces to the audience that they can't do when they're like this. Okay? So you have to begin to use the tools that we have available to us. And I would encourage you to do the same thing. Now, you need to know who you're presenting to. Most CEOs are used to what sort of presentations? Anybody? Do they get hour-long presentations like I'm doing now, slide after slide after slide? They might be handed that in a packet so that they can spin through the 60 while you're talking, but they're going to expect somewhere less than 10, probably in the 5 to 7, one of them's your title slide. Right? So you have to know who you're presenting to, right? And if they're more on the clinical side, you're going to be stressing quality, safety, and those sorts of issues. And if they're more on the fiscal side, you're going to want to be stressing some of those issues more, right? And might be having to blend both. So knowing your audience, knowing what executives want out of you in the presentation that you're going to do, use a story if you can to really connect. Last week we had a patient who stayed a long time in the ICU. Our organization interacted with physicians who have come back and told us that they went back and improved the care of their diabetes patients, and their patients were at risk prior to attending our event. We heard from a patient group that said, thank you for providing that education. We think you're moving the ball in our multiple sclerosis or whatever the disease might be that that patient group represents. Use a story that helps them see your connection into healthcare and your understanding. And I would stress that you want to use the phrases that you are a lever, an asset, a value, as many times as you can. I actually like presenting to the mix of the clinical and the fiscal to try to create that balance, but you may not, and you may not be given that opportunity.